Welcome to Health Reform 2.0, the only place on the internet for people with a curious mind and a desire for a better healthcare system. Here we take you on a journey of our current quagmire, tell you where it came from and why the government can't fix it. Along the way, we'll tell you some history, bust a few big myths, tell you a few stories, and give you an idea how we can work together and get the healthcare system we want. Let's get started. Welcome again, ladies and gentlemen, to another episode of Health Reform 2.0. This is episode 6, A New Approach. Today, my co-host Tim Henning and I are going to talk to you about an outline of a system we think can be put in place that can actually make for an effective healthcare system. We've taken all the things we've talked about in the history lessons. We have created an idea, a design for how we can take the mess that we have and actually get an efficient, effective system that should lower cost and provide better services for all of Americans that will help us guarantee that we can get the care we need in crisis and also continue to get the care we want by choice. So today's episode is going to discuss this in a little bit more detail. We will probably have a series of other episodes that'll come later talking about the various points. But now I want to introduce my co-host, Tim Henning. Tim has been on this ride with me for quite a while. And Tim, what are we going to learn in the show?
Well, thanks, Tom. It's been a good ride, and we're going to continue with it. As you mentioned, we got through the history lessons. So today, we're going to start to talk about what almost all of us agree on of what we want with our healthcare system. And you know, Tom, I don't think it's something most people have really ever truly thought about.
Well, probably not, Tim. And I tell you the truth, most people, when they do think about it, we think about it from a very personal view.
Exactly. So by and large, the nation has been in somewhat agreement with the basic goals and objectives of what we want from our healthcare system. During the work on his Health, Education, Labor, and Pension Bill, Senator Ted Kennedy crafted a set of objectives that Republicans and Democrats could get behind.
He did. And one of the things that the Health Bill had done is it had really come to grips with not only what America wanted, but what America needed to have in a healthcare system. And Kennedy was able to get bipartisan and bicameral support. Bipartisan means both Democrats and Republicans support it, and bicameral meaning that there was support in the House and support in the Senate for the legislation. Of course, the Health Bill never got any further than a concept that he had worked on since Hillary Care. So we are actually all in agreement with what America wants. So what does America want? America wants available and accessible coverage for all. That's 100% of Americans. We want affordable coverage for Americans. We also want affordable coverage for America. That's not the same thing. We want to have minimum standards of care we are guaranteed when we go to get services. We want affordable coverage regardless of pre-existing condition. We want affordable coverage regardless of disease state. We want reductions in the overall U.S. cost of care, and we want reduction in the individual cost of care. And again, those two things are not the same. We also want to ensure coverage for the underserved, and we want to provide an effective safety net for the helpless and filter and support the clueless and get rid of the fraudsters, what some people call worthless.
Exactly. So it appears that the agreement's probably the easy part, although I'd question that now based on the tribal warfare that we see in the Congress. And yeah, we can actually see that we all basically agree on these goals. So tell me, why does government intervention go so horribly wrong, and what's stopping us?
Well, you and I have talked about this a lot over the history series and in the last episode as well to some extent, but it is what I call the plague of myths. Part of the biggest problem we have in trying to get beyond what we agree on is understanding exactly what it is we have today. And that, my friend, is a huge problem because, as you know, Tim, not everybody in America has a clue about what medicine can actually deliver in the first place. For instance, I'll go through some of the myths. You feel free to pick up some of them as well. But the first and foremost that you and I have discussed is we have a healthcare system. And you and I know we don't. We have a quagmire. We have a series of self-predatory practices and methods that promulgate massive problems, massive fraud, massive waste, massive cost, and the inability for us to actually coordinate care and benefits across all sources. So we've got duplicated services and all kinds of other problems.
Exactly. We also have a myth that we have cures for everything, and we don't.
No, and that in and of itself is a problem because we believe we've cured these things, and in reality, we still are facing them today. Mother Nature is a bitch. She keeps on going and coming up with ways to purge humans from the planet because she doesn't want us to overpopulate. Our job is to evolve and get stronger, and Mother Nature's job is to continue to evolve the other things that prey upon us to help keep us in check. We've taken ourselves out of evolution for a long time, and as a result, we're actually less prepared to deal with these things today. We also believe that what's good for us as individuals is also good for the human species. And as I said before, that's simply not the case. Treating ourselves to be exempt from the ravages of disease still keeps us alive, but it allows us to have children that have not been selected out because they were sick from the disease. They are now selected still to stay alive because we've got, in effect, a cure for them, but they're carrying on the susceptibility to the disease, and then succeeding generations are getting sicker and weaker as we go on.
There's one more myth that stands out amongst these, and there's a lot. One we spent some time on, and that's the myth that seeking and getting health care is relatively safe. It is not, by any stretch of the imagination.
Exactly. Healthcare is getting more and more dangerous, and as you and I know, we did a study a few years ago in 1999, and it showed that 260 out of 100,000 people died seeking healthcare. And the next thing in the list is the most dangerous occupation on the planet, commercial fishermen, and only 200 out of 100,000 people die from that. What's most interesting is they redid the study in 2013 that we based our study on, and if we use their new numbers, it would be almost twice that amount. We would almost be up to 400 people out of 100,000 people dying from healthcare today. One other big problem we have is we believe that when it comes to healthcare, what we think we want is the same thing as what we need. So we don't really do much to go between what we want in care and what we need, and that's very different, don't you think?
Absolutely. I kind of equate it to, I fly a lot, right? And I get the basic service, the thing I need to get me from point A to point B when I fly in coach, and I pay coach prices. On certain places I go, I won't fly coach. I fly first class because I got long trips. And I pay for that. In healthcare, we blend those two together.
Right. And then there's a series of things that I'll call insurance-driven problems that we believe have been good for us that really have not. For instance, we believe that employer-sponsored insurance has been a good thing for healthcare in America overall. It really hasn't. We believe copays and deductibles have helped actually lower cost and reduce consumption. And that's also clearly and provably not true. We believe that America can afford it, whatever it is. That's another big myth. And we also either believe that the government should have the only role of providing care for America, or the other side is believing that the government shouldn't have any role at all, and that's also two sides of an equation that don't equate to reality. We also believe that America's health care costs too much. And as a result of these myths, and as a result of that one in particular, we think that somehow we're so much more expensive and our outcomes are so much worse than the rest of the world. But the rest of the world is not counting healthcare the same way we are. We're trying to count it all, and we're counting it poorly. The rest of the world reports what their government spends on care. England, France, Spain, others. And that, in many cases, is between 40% of the spend and 60% of the spend that is spent in the government, meaning that somewhere around half or more than half is actually in a private market that in most of those countries is a black market or a gray market that isn't counted and isn't acknowledged to exist. So we believe these things. We've inculcated them into who we are and how we perceive healthcare, and that taints our ability to have a good objective view of what healthcare is. We need to understand that what's good for individuals is not always good for the nation, and that individual cost needs to be balanced by the cost of the nation, and that we have to dispel these myths. These are the things that we need to take away from this.
There's one more thing I'd like to add that plays into that. And you mentioned that the way we account for the cost of healthcare, it's inaccurate.
Exactly.
And there's no transparency in this system whatsoever. And so when you think you go in and this hip replacement is going to cost $50,000, that's not what was paid to the provider by any stretch. I mean, they may have got 23 cents to the dollar of what they billed.
Right.
So you've got, what am I call it, in retail, you're going to call it list price. You got discount price. Well, guess what they're counting? They're counting the list price. And you as the consumer, you as the patient have no earthly idea what this costs until after the fact you get your EOB, explanation of benefits, and most people don't even understand that.
It is a huge problem. The entire health economy is a false one. You and I have talked about that in the history series. The last episode we talked about is how the government's basis of funding programs is actually raising prices by the way the math works. We won't go into that here. But our general belief in how healthcare works is a plague, literally a plague of myths. And for us to move forward, we have to dispel the myths, we have to ignore the myths, and we have to start to focus on a pragmatic approach on how we can get checks and balances and a system in place that can lower costs, deliver the care we need in crisis, and deliver the care we want by choice.
Absolutely. So we also need to recognize that many patients can't figure out healthcare on their own. They need some help. They need someone to point them in the right direction to help them understand and navigate through their healthcare needs, and in some cases, when they become chronically ill, how to maneuver through those landmines.
And ultimately, the problem is, as you said, is healthcare is a quagmire, and you really need to figure out your way through it. Doctors are very good at trying to figure out the medical process that they're using and work with other providers, but they hate dealing with insurance companies, which we call sponsors. And the sponsors don't particularly like dealing with the doctors. They definitely don't want to deal with the patients. And the problem overall is we have 3 legs of a 4-legged stool. And those 3 legs don't interface with each other. And then you have the poor patient, as we've talked many times before, who is literally not in the loop when the care is being driven. And as soon as the payer, the sponsor, the insurance company, the government, whoever steps in to start to deal with the bill, the patient is thrown completely out of the picture. So we've got a mess here. We have a stool that doesn't stand on really any legs, because at any given point in time, it's not even a 3-legged stool, it's a 2 or 1-legged stool. We need to develop a system that has 4 legs to this healthcare stool. And one of those legs that we're talking about now is the need for a role called a facilitator, something that doesn't exist today. If you look at HIPAA, and if you're not a spouse or a wife or intimate family member and you try to talk to a physician about diagnosis or treatment, you'll find it's very difficult to have any conversation with them because they're worried constantly about HIPAA and HIPAA violations. We need to define the role of a facilitator. So we see 4 legs in a healthcare stool. We see the patient, who we really want to start to call participants. And Tim, why do you think we want to have them called participants?
Because we want them to participate in their own health care and be accountable and be educated, and not just be led around by lambs to slaughter.
Exactly. And every time you bring this up to somebody in healthcare, they come back and say, well, you can't leave it to patients to figure it out. They don't understand it. They can't figure it out. So what have we done, Tim?
Well, we've basically tried to dummy down the whole situation. And again, there are people that need help. There's clearly people that need facilitation.
Exactly.
They need to find sources of how to pay for this stuff too. And there's many other sources out there as well.
Right. And we do have the role of facilitator in our expanded healthcare system. When you look at what some states do in government programs, where they have social workers and case managers paid by the state to help, as an example, HIV and AIDS patients figure their way around the problem that exists in our healthcare system. And those facilitators often are being paid by the state or federal government to help those patients move forward. But we're envisioning a role of a facilitator that becomes a formal role that is really anybody that is helping somebody get or manage their care needs and wants. And that includes many subgroups, not just caseworkers in the formal sense, but faith-based people that help. We have social workers and caseworkers. We have family and friends and children. We have guardianships. We also have people that volunteer and friend next door and librarians and public service people. They have to be able to work between the patient, the provider, and the sponsor to make sure everybody's abreast of what's going on, to reduce duplicated services, reduce fraud and abuse, and to improve outcomes by making sure the patient understands what they need to do and adheres to the treatment necessary. So to recap, we're looking at a system that has 4 legs of a stool. Patients, who are the people that need care and want care. We have facilitators, the people that help them get the care they need and want. We have providers, which are obviously people that provide care, like physicians, doctors, nurses, and nurse practitioners, pharmacists, therapists, and many, many other subspecialties. And then we have sponsors. Sponsors are the outside people that pay for services that include the federal government, state and municipal governments, philanthropies, corporate players, insurers, and even volunteers, people that volunteer to provide free service. They should be all considered as part of a sponsor category.
Yeah, this is highly overlooked, and I'm sure that many people in the audience are acting as facilitators today for a loved one, a family member, whoever. I can show you multiple examples. We do that here in our household with my wife's mother. There goes a Kaiser, and we help manage that, and it works out well.
Exactly.
So I can give you plenty of examples of where you don't have a facilitator and you get lost in the systems because it's very easy for the patient to be ignored.
Exactly. And one of the other things that we need to deal with in this is we need to re-educate ourselves on this concept of the confusion of what we need and what we want. And while it's really easy today to think of, well, I'm sick, I need this, many of the things the physicians are doing for us are not really around what we need. There are things that get done for us that go beyond need to things we want to feel better or feel good about ourselves afterwards. And again, we're not advocating that it shouldn't be done. We're advocating that they need to be recognized as 2 distinct things in the system. Because if we're going to provide safety nets and we're going to do something that's going to be focused at cost effective and regulated, then we need to focus on their delivering the need. On the other side, where it goes beyond that, it should be on the want side, and that should be where people go get those services they want. And those 2 systems have to be separate, or else you're going to have the same problem with cost shifting we have today.
Exactly. And we need to think of the roles and responsibilities of the providers. And providers are physicians, PAs, therapists. It's a whole bunch of different people within the system.
Yeah.
Not a good word, the quagmire, but
yeah.
But everyone taking care of us must be in contact with everyone else. Now this becomes complicated. If you're in a closed network such as Kaiser, it works much better. Some IDNs believe that they're actually good at this or not very good at this at all. We've talked a lot about that. HIPAA gets in the way because you got to remember, this is a predatory and hostile economic environment.
Right.
Everyone was talking for years that IT was going to solve everything. Electronic medical health record was going to solve everything. Everything would be talking to everybody else. You'd know everything. How's that working out, Tom?
Well, we know now that that's not working out very well. In fact, there was a study released, I think we saw it, about a month ago, and it came out and basically said that it now seems like electronic health care, electronic medical records have made doctors' lives more difficult and actually are making care more dangerous again.
Exactly. And if you think about this, if you're going outside that network or going to somebody else, they are competitors. Why would they ever talk to each other?
And, back to the concept of roles and definition of roles, we have doctors delivering care and being responsible care that nurses are fully qualified to do. We have nurse practitioners in the game that are qualified to do other things, but still we have doctors in the loop. We're not comfortable going to anybody other than the doctor because we have 100 years of inculcation by organizations that you have to go to a doctor, you have to go to a doctor. We have a wonderful, most accessible person in the entire healthcare scene, the pharmacist. And in almost every country, you can go to a pharmacist and get basic care. They can stitch wounds, they can prescribe basic medications, and they can do a lot of things at a pharmacy in other countries that pharmacists in America are actually trained to do, but they're not allowed to do them because of the way licensure is working state to state. So I really do think we need to sit and rethink the roles of doctors and surgeons and subspecialties and nurses and PAs and all the various players that work. And we have to have an intelligent discussion about, should a pharmacist be able to do some of these things, because there'll be lower cost, easier access, and less cost to the public when they go there. And these are the kind of discussions we have to have about redesigning the system. There is clearly a better way to do it.
Back to the pharmacists, nothing more that irritates me are these gag orders imposed on pharmacies and pharmacists that won't allow a pharmacist to tell a customer that you may have a different place or different location or different area we can go to get that drug for a much less price. They're restricted by law to do that.
Right. Right. And the other thing, too, is remember that in the system we're proposing, there won't be any state borders, and it'll be universal and fully transportable. And in the long run, most of those artificial barriers exist because the way licensure started, there is no federal medical license. There is no federal insurance program. But there can be a mechanism, as we're describing, that will allow every insurance company to provide the same base kind of policy that will allow full transportability so you can get that care and service in any state from any licensed doctor. The federal government, as an example, could take the state licensure of a physician and grandfather that under a federal license that would be the controlling license for insurance companies to pay for those goods and services. These are just some of the ideas that we're going to talk about here in a second as we get into this idea of a new system.
Yeah, in this new system, we want to put the patient at the center of his or her healthcare universe with tools that allow them to do that.
And it needs to be a single point of access of care, as you said. And it needs to be able to fully coordinate care and benefits across all available sources, so that when a patient is in the system and they're dealing with someone else, that person, a facilitator, or if the patient's doing it on his own, when they go look to talk to one doctor in the system, they actually are really talking to the patient, and the patient is making that electronic connection to the doctor. If everything is flowing through the center, through that center blue column there, the patient is, in effect, the gatekeeper of his information, and a doctor never needs to talk to another doctor. He doesn't need to talk to the insurance company. Everybody, in effect, asks the electronic patient, and the patient then gets the information and passes it out. It's all electronic. It's not something the patient is in the middle of. He's not doing anything. But that way we change the relationship to a truly patient-centered system. It is a full transactional patient-centered system, and then it can be national and override what happens within a Kaiser or within a Sutter or within a Blue Cross and Blue Shield. They can still do things within their confines the way they want, but when you talk to the patient, you are able to talk to anyone that's treating that patient that the patient's given you permission to talk to in their care universe. That means you're coordinating the care through everybody treating him. You're duplicating less services. You'll have less bad drug interaction, less bad treatment interactions, because everybody's now kind of aware of who's doing what. When I talk to Tim Henning, I see everybody that's treating you, and I have access to communicate with them as long as you've given me permission to be in that world.
And having the patient at the center eliminates all this HIPAA stuff, as you described, because all these other folks have agreements in place that cost money to share that information.
Exactly.
Unless you're within a confined system.
Right.
So having a central point of access is very important. We need to repurpose that and understand that.
And if you look at the slide we have on the screen, you'll see that we're looking at these four legs of the stool. We're pulling up, as an example, a facilitator. And you'll see that the facilitator has a series of things that they can do to help that patient. It's in the right-hand corner. We call him Morgan. Get answers to all the questions that they need to help him know who he's seeing, what's happening. There are tools that allow them to be able to see what's going on between each doctor to help Morgan understand what's happening, and also to help make sure that the right hand and the left hand know what each other is doing. It's really important in care if we're going to reduce up to 60 cents of wasted funds on every healthcare dollar by reducing duplicated services, fraud, and abuse. Coordination of care and benefits across all available sources has to happen. And that doesn't mean coordination within Kaiser and then no coordination with another physician outside. It has to be all within a massive organization tied directly to the patient as the center point.
Exactly. Let's kind of bring it to life for a minute. So you go into your physician, you have a blood work done, and as I've just done, and let's say, for instance, it comes back with an elevated PSA. More than likely, my physician is going to refer me to a urologist. What's going to happen, Tom, when I go to that urologist?
Well, I can tell you from firsthand experience, because I've been going through this now for a number of years as a result of a diagnosis of prostate cancer I had years ago. Fortunately, I didn't have a big problem with it. It got resolved fairly simply. But when I go to see my GP, he orders a PSA. And I'll go sometimes 2 weeks later to see my urologist, the way the schedule works. And what does he do? He orders another PSA. And I have often said, why are you ordering a PSA? My GP just got it. He said, because I really need to order it so that I have it here. Well, you and I know that is partly true. They're not always guaranteed that the lab is going to forward them the result, even when it's put on the list. But the other problem is he gets paid to do that. And when the bill goes to the insurance company pays them both because there's no way easily for them to coordinate the duplicated services, particularly when one is in one network and the other is in another network. Whereas in our system, the insurer, who we call a sponsor, whoever's paying the bill, knows who else is in there paying bills. And then they can coordinate their payment across all the other people, because I may be eligible for reimbursement through a number of different programs, not just insurance. There can be nonprofits that are interested in the disease and willing to help pay for treatment. There can be drug companies that are willing to help offset my copay or to help pay part of the service fees. I have that going on with one of the drugs I'm taking today. And if my insurance company doesn't know that's happening, they may double pay the claim or double pay at least part of the claim. In this system, everything is there, everybody's working to help each other, and as a result of that, that concept of competition and I'm just going to order it because it's a reimbursement, it would be immediately shut down. And it would be shut down basically at the patient level because it's patient-centered. That patient-centered system would see that other bill come up and notify that doctor that it wasn't going to be paid long before the insurance company would have to deal with it, unless the doctor was able to provide some true justification on why they needed a PSA a few days after the other one.
Exactly. I think when I had my eye surgery, I had to go through 3 different ultrasounds on the same eye by the same retinist, actually 3 different retina surgeons. So
exactly.
Why did I have to go do that? I think I know why, because when the guy was dictating the results, he made sure to thank the referring physician in the dictation for his referral.
You betcha.
Go figure, guys.
You betcha.
So, Tom, what we should talk about now is the 2 integrated systems that we discuss a lot, life care and the quality of life care. Can you explain what those 2 are and the differences?
Sure. Well, as we said before, we have to start to unhook need and want in our healthcare system, because need is the things we need in crisis to keep us alive and productive, and want are the things we want to have better quality of life and to feel better about ourselves. And in many countries, they only deal with the need side. The universal care systems really focus down on need, and the quality of life side, the things you want to feel better about yourself, most of the time are restricted or don't exist. We as Americans aren't going to be too happy with that, no matter how much we want this universal system. I think we're going to recognize that's going to cause significant changes to what's happening today. We don't need to go through that now. We'll do another episode on it. But life care has really first got to start with redefining what our expectations are to base care. Base care is the things that keep us alive and productive. And we need a system that's going to keep that price low and make sure that whatever happens to us, there is a system we can get it fixed and get back into work and get back into life, supporting our family, supporting ourselves. And that's what's very important. The next is we need to make sure that life care is affordable. It has to be easily affordable, not just for us as individuals, but it has to be affordable for America. It has to be affordable for all of us. We can't have a system that is going to make it affordable for us by making it unaffordable for the rest of America by constantly increasing taxes, thinking that somehow or another that's not impacting us. It does. We've showed that in earlier shows. We need price transparency. That is, transparency is price transparency plus price certainty. We need to know that what we're being charged is actually what the physician is getting paid. No more of this, oh, it's a $1,000 procedure, but I'm only going to get $220 for it. We need to allow policies and a system that crosses all borders, state, federal, whatever. It has to coordinate no matter where you are. And all plans have to be the same and transportable at the base level. Whether you get that basic plan at Aetna or Blue Cross and Blue Shield or Sutter or whoever or Kaiser, that plan should be the same and cover exactly the same things. Is it a minimalist plan? It's minimalist and it covers everything you need. It doesn't provide for what you want. And we need to describe that plan and say to all insurers, you offer this, you can play in the quality of life market. If you're unwilling to offer a base level plan, you can do nothing over there. So that's the idea. This should be the bargain basement thing that we all get that gives us the basic things we need to stay alive. And the last thing I want to say, that we don't need a network. The insurance company does not need networks. It doesn't need to artificially put ourselves in smaller and smaller buckets. It needs to be able to be everybody in that base plan spreads the cost against everybody else in the base plan. We all know the larger the actuarial pool, the lower the net price to each person. And insurance companies have done it at a minimum by state level. You've never seen a pool larger than a state. And by the time you get down to employee-sponsored plans, those employee plans are often, the actuarial pool is the number of employees in the company. The fewer the employees, the larger the risk to the individual, the larger the policy price. In this case, from this base policy, they're spread across everybody that has a base policy in that insurance company, whether they're in Philadelphia, California, Minnesota, or Timbuktu.
Exactly. And then you could have on the other side of the equation things that you want.
Exactly.
People can participate in that. But that comes at a different price point, a different policy. Again, it goes back to my analogy of flying. Right. On long haul routes, you got coach, you got business, you got first class. And you have to make a decision of where you want to be within that. But if you're in coach, you have a good chance you're going to get from point A to point B and get everything you need to get done the same way that person paid more for in first class. You just don't get the champagne that goes along with it.
Exactly. But if you want the champagne, you can get the champagne in coach. You just got to pay for it. And in this case, that's a good analogy because in the quality of life side, the stuff you get over in the life care side is now coordinated to anything you're going to buy on the right side. So it's all going to show up in your system. And you can get, as you said, an insurance policy that it's a rider that adds additional things you may want, that you might want in the future, the kind of wants you may want. And the insurance company can sell those to you. And they can sell them to you at more of a market rate because this isn't a regulated market. This is an open market. The laws of supply and demand will exist there. The other thing is you don't necessarily have to have an additional insurance policy. You can use your HSA to pay for these things. So when you want something, you want dissolvable stitches that may not be provided on the other side, or you want some additional cosmetic thing to deal with a scar you had on your face that's not covered to get you back to work, you can pay that out of pocket. You can pay it out of a policy rider you've purchased, or you could pay it out of a savings account. We'll talk in another show about how we need to modify HSAs so that they become more appropriate going forward. The other thing is you can pay out of pocket at time of service, and you can negotiate with your provider, unlike on the insurance side today. You can negotiate with that guy on there. If he says this is what he wants and you can get him to do it cheaper, that's up to you. But no one is standing between you and the doctor in either side of this. Your relationship with the doctor is inviolate. The insurance company is not telling the doctor what to do in either case. He's not debating with the doctor whether something was necessary. In life care, the protocol is established. If the doctor does the protocol, they get reimbursed. If he wants to go beyond the protocol and you want to go beyond it, you negotiate that in quality of life. The insurance company isn't playing in either one of those. So we think that it is really a good way to look at it. We can put the hospitals in the game through what's a typical hub two-step service model. We can keep our private physicians. And the last point is, if we go to a universal healthcare system, there's no money in the system that's going to help fund research and development. That's one of the big criticisms you hear from one side all the time on going for universal care. And in life care, that's true. But research and development will happen on the quality of life side, because initially those things that improve care will come in over there. And as they become necessary to lower cost and become part of the expected care, those things can move over into the life care side. And now you've got two things, and you won't have what we've had with Medicare, Medicaid, and private insurance for 30 years, cost shifting. You won't have the life care side continually reduce prices because the doctors on the other side are going to be able to make it up over there. In this system, they are balanced out. They're coordinated on both sides. So if we see that one thing is getting too cheap, and we can go back and balance it out. So a doctor doesn't have to play in both to keep practice. Like Kaiser is an example. Kaiser is kind of already there in a life care model. They do a lot about helping people get the care they need. They don't do as much on the want side. Kaiser is a very good understanding of how the life care side could work. And some companies like Kaiser may say, I don't want to do quality of life at all. I just want to do life care. But like it is today, if you're at Kaiser and you want to get those other things are now out of network, and they're going to cost you a lot more money. In this thing, they're never out of network. In this thing, they're coordinated, and they're always managed together.
So those are some of the ideas. We've got a lot more to talk about on how that actually works in upcoming episodes. Anything else here, Tom, you want to talk about?
No, I think that's pretty good. I think we'll move on from this, and we'll do some more episodes on various points in here as people bring up questions and go into a little more detail. But the point at this time is to start to do shows about the here and now, and to really talk about what's going on in healthcare, and to start to talk about how this kind of an approach can help improve the things that we've highlighted as problems from the history lessons.
So the only way this is going to get fixed is with us, we the patient, we the people. Government can't do it. We've proven that time and time again. I think we beat that horse to death. So we got to step up. We have to be the ones to do it. And I hope that this and our future episodes will help us understand a better way to do this.
I agree. So again, Tim, thanks for being with us on the ride. I'm glad to have you at my side. And we hope the audience has enjoyed this show. And we look forward to seeing you again in the next episode. You've been listening to Health Reform 2.0 with your hosts Tom Locher and Tim Henning. We hope you found the topics interesting, that we answered a few questions, that you laughed a bit, and were entertained. Please feel free to invite your friends to join the discussion, and remember, hit that like button and don't forget to subscribe. Send us your questions to info@hr-20.com. We hope to see you again next time.